Some of the inspiration for my remarks today come from this great paper that was published in the New England Journal of Medicine about a year ago by Smith and Hillner called Bending the Cost Curve in Cancer Care. And what they did was articulate 5 attitudes and 5 patterns of practice that need to change if we're going to do anything about costs in cancer care. First was to acknowledge that we, practitioners, drive the costs of care, that we need to become more realistic, both doctors and patients, about our expectations of what cancer care can do. Realign compensation to balance cognitive services. In other words, to not just pay and overpay for giving chemotherapy procedures, things like that. Integrate end-of-life, non-chemotherapy oriented palliative care into our care processes, and accept the need for cost-effectiveness analysis and some limits on care. In terms of practices, the first one is about surveillance, and we could have a whole session on that, the follow-up of patients who have been potentially cured. But the other ones are all about how we treat patients. So, for example, limiting the way that we give metastatic treatment, especially in the second and third line for incurable disease, keeping it just for patients who have good performance status. Doing simple things like reducing dose rather than using expensive growth factors if you run into hematologic toxicity. And if patients really aren't responding to treatment, that there's a time that you should stop or at least limit care to clinical trials. So if the title was Bending the Cost Curve in Cancer Care, why such a focus on end of life? Well, the reason is that every cost trajectory for every cancer that I've ever seen has looked like this. This is lung cancer patients who live 6 months, and what you see is a U-shaped curve. At the beginning, there are costs at the time of diagnosis, initial treatment. Costs go down during the continuing care phase, and then in the last month or two is when they ramp up again. So care at the end of life is an important driver of costs. About 10 years ago, I started a project that was trying to identify quality of care indicators for patients with advanced cancer. So not specifically end of life at the outset, but just the incurable cancers. And what we found when we searched the literature and did some qualitative work with focus groups and expert panel, et cetera, was that the themes that emerged ended up being essentially all about end-of-life care. The overuse of chemotherapy near death, the underuse of hospice and palliative services, and the misuse of interventions that result in patients landing in the emergency department, hospital, intensive care unit, et cetera. We just heard Zeke Emanuel talk about that at lunch. You've got 6 months, but with aggressive treatment, we can help make that seem much longer. So a medical oncologist in one of our panels said, we can treat with many lines of chemotherapy in appropriate patients, but there's a time to stop. And that's something that you don't hear us say all that often. I've come to terms with dying from my cancer. I don't want to die from complications of the treatment. Another thing that I think resonates with a lot of oncologists, for most of our patients, a visit to the ICU is kind of a failure. And a bereaved family member looking back and saying, I think the earlier that a doctor mentions hospice, the better it is for the patient, because the patient could plan for things ahead rather than spend so much time doing treatment. When we started looking at some of these issues using data, and these are Medicare patients in the United States, what we saw is that for most of them, over time, there was a steady increase in the aggressiveness of care that we were giving. If you look at the associations, in the interest of time, I won't go through all of this. Some of it is things you'd expect, like younger patients are more likely to undergo aggressive care, et cetera. If you go down to the bottom, the last couple, so being in a teaching hospital was associated with more aggressive care. That may not be unexpected. But just being in an area where there were a lot of teaching hospitals, there's something about the culture of being in Boston, say, or something like that, that made care more aggressive. And then the very last line is something that I think is quite important, and that everywhere I've looked, the same thing is coming out, and that is that if there is less access to hospice or palliative care, the aggressiveness of care is more. So if there are fewer hospices in your area, this is US data, you're more likely to receive chemotherapy till the end of life. You can imagine why that might be. Part of it is us as oncologists, if we don't have support, palliative care, hospice, etc., we do what we were trained to do, which is to give chemotherapy. So I've shown you American data. The question is, does the same thing happen, has the same thing happened in Canada? These are data from Ontario showing that, again, in general, with the exception of hospitalization rates near the end of life, rates have been steadily increasing, at least into the mid-2000s. Our rates of emergency room utilization in the last 30 days of life, very similar to the US. We do give less chemotherapy, although the trend is still in the same direction, and less use of the intensive care unit. Hospitalization is one where, if you go back into the early 90s, rates were quite similar between the two countries. There's been an increase in the US and quite flat in Canada. But is this a quality of care issue? Is the aggressiveness of treatment that we give to patients near the end of life really something to do with quality? We have a lot of rationales for why we give futile treatment at the end of life. The evidence shows that the aggressiveness of the chemotherapy or of any treatment that we give near death is actually not related to the likelihood of success of that treatment. We often say that it's the patients that are requesting it, patients or family members, that it's seen as preserving hope or being a fighter or a winner. Doing something is better than doing nothing. And it's easier for us. It's easier to say, let's try mitomycin C, than it is to sit down and have an honest and frank discussion about the end of life. Patients will accept more toxicity for less benefit than healthcare providers would. This has been shown in a few studies. And so people use it as a rationale for saying, well, we don't have the same values as our cancer patients, and so we can't make decisions for them. If they want to continue with aggressive treatment, that's what we should do. I would actually say that we should use that, look at that differently. If healthcare providers who are experienced in treating cancer patients would not take a certain treatment, it probably means that we've shepherded many patients through this whole journey. We've seen what the trade-offs are and know that something is likely to be more harm than good or not worthwhile. So I think this actually might be a situation where some paternalism is actually useful. And lastly, financial incentives. Probably less in Canada than in the US, but it's still what we get paid to do, is to treat people. Does the aggressiveness of treatment improve survival? These are some data, again, in lung cancer using instrumental variable and propensity score analysis to try to tease this apart a bit. In the thin solid line, where you see patients who did not receive chemotherapy. The other two lines are people who did receive chemotherapy, and as has been shown in randomized trials, patients do live longer if they've received chemotherapy. For oncologists, this is a big deal. I know the curves look very similar. But the two curves on top, the dark solid line and the dashed solid line, the dashed solid line is chemotherapy that's aggressive in some way, continued very close to death, for example. And what you see is that there's no detectable survival advantage from that. People also say, well, hospice, if you give up and send people to palliative care or hospice, that's going to have a negative impact on their survival. Again, observational data, but this has been shown over and over again that patients who actually use palliative services in hospice, if anything, the trends tend to be that they do better. So in the first one, the dashed line is patients who do have a hospice stay versus those who don't. And then in the closer to me panel here, it's dichotomized by the length of hospice stay. So there's no hint, no signal that patients spending time in hospice has a negative effect on their survival. And in fact, this has now been shown quite nicely in a randomized trial that was published almost 2 years ago, again in lung cancer, which is a good disease to think about this for. Patients were randomized to early initiation of palliative care or not. And those who received early palliative care had a better understanding of their goals of care, of their prognosis. They received less aggressive care at the end of life, less chemotherapy in the last month. They were more likely to use hospice. And probably a bit surprising, there was a 3-month survival advantage to the early institution of palliative care. The next couple of slides are just about relating things to the aggressiveness of care. This one was a small study where bereaved caregivers were surveyed using the FamCare instrument, and caregivers of patients who had received what we term aggressive chemotherapy, who died in hospital or in an intensive care unit, or had no hospice or palliative care, there was worse satisfaction overall with the care. Similarly, in a large 10,000 patient NIH-sponsored consortium, bereaved family members rated the quality of care to have been better with fewer unmet needs if their loved one did not receive these measures of aggressive care. And Alexi Wright has published in JAMA that more aggressive medical care in cancer patients towards the end of life is associated with depression in the bereaved caregivers. So I think there are quality issues here. Can we change practice? This is an interesting study that needs to be repeated because it's over 10 years old. It was in JAMA, and they looked at the end-of-life care content in 50 textbooks from multiple specialties. And out of 12 specialties, hematology-oncology textbooks ranked 10th. The only ones worse were infectious disease and surgery. And you can imagine we see ourselves as part of that curative paradigm, like curing infections and heal with steel and all that sort of thing. Family medicine, geriatrics, et cetera, have much more. ASCO, the American Society of Clinical Oncology, has something called the Quality Oncology Practice Initiative. And at the time of this study, there were 125 practices. And they looked at some of these end-of-life care measures. They've incorporated them as quality measures. Chemotherapy use within 14 days of death ranged from 0 to 53%. It's a huge range in participating practices. And here again, strongly correlated with admission to hospice. This is the type of thing that leads to the joke that I'm sure you all know: why do they put nails in the coffins? It's to keep the oncologist out. This is the span of patients enrolled in hospice before death, ranging from 25% to 100%, with a mean of 62%. So huge variation. And in a study from Michigan that was published in the Journal of Clinical Oncology, again using the COPI program, prior to COPI feedback in the initial measurement, chemotherapy in the last 2 weeks of life was being administered to 50% of patients. And with feedback, so these are people getting data about their own practices, that went down to about 20%. So I'll just leave you with this thought that I think it's important for us to recognize these issues, to recognize that they drive costs, which is the main focus of today's meeting, but also that there are quality of care issues for patients, for their family members. And I think we have to be careful not to become practitioners that specialize in futile treatment. Thank you very much.